So in this chapter, we'll discuss positioning for cranial surgery. The key concepts is that position is crucial for successful intracranial surgery for a number of reasons. It affords safety for the patient and protects the patient for long-duration surgeries. It provides a direct trajectory to the surgical target while accounting for tumor projection and eloquent errors. It facilitates brain retraction with certain types of positioning. It enables reduced intracranial pressure by elevating the head and allowing CSF drainage. And it also allows ergonomic ability for the surgeon to operate comfortably. In general, we position the body before we fix the head in the Mayfield three-point headrest. We choose one of the following positions in most cases: prone, supine, lateral, or sitting position. And then the head is finally pinned, and the surgeon is there to position the head specifically in the position that he or she would like it for by adding flexion, rotation, or neck extension for the ultimate positioning to provide the trajectory to the surgical target. And finally, padding is placed and the patient is secured to the table to enable the table to move and tilt left to right, elevate, or Trendelenburg or reverse Trendelenburg positioning. This is our standard pin placement for arterial craniotomy. We may add a shoulder roll under the ipsilateral shoulder to enable the head to be turned without turning the neck and obstructing any venous return. Please note that the positions of the pins can be biparietal here or can be occipital and frontal, depending on the target. For arterial craniotomy, we place the patient supine on the operating table. It's reflex to keep the head elevated to enable brain relaxation. The shoulder may be bumped, as I mentioned, depending on how much the head needs to be turned. And we try to minimize the turning of the head. We elevate the patient's leg in a reflex position and place the lower extremities in compression devices. We use various amounts of reverse Trendelenburg position to promote brain relaxation. And as the last step, the head is secured in the Mayfield head holder. And two options for pinning are possible. A single pin is used in the contralateral frontal bone with occipital dual pins, or as I mentioned and demonstrated in the previous picture, biparietal pinning is possible. It's important that whatever pinning protocol you'd like to use, the pins must be placed below the equator of the axial plane of the cranium, such that the head falls into the pins and it doesn't have a tendency to fall out of the pins. The amount of turning of the head with a arterial craniotomy is determined by the pathology that you're needing to address. We apply slight lateral flexion and the neck is extended, and the head fixation is then secured to the table after final positioning. The patient's arms, knees, and feet are padded, and the patient is secured to the bed with a safety belt or strap to enable rotation of the patient in a lateral position or elevation of the head with reverse Trendelenburg or depression of the head with Trendelenburg positioning. Here's an example of a picture demonstrating a standard arterial craniotomy as used to approach a anterior circulation aneurysm or cellar or suprasellar tumor. Here's an example of a patient placed in a single pin in the frontal bone with occipital pins. And you can see we place the frontal pin in the midpupillary line on the contralateral side to avoid interference with elevating the flap. Now, for a temporal or subtemporal middle fossa craniotomy, we usually use a large roll under the shoulder on the ipsilateral side and then turn the head so that the sagittal sinus is parallel to the floor. Here we're planning to approach a vestibular schwannoma using a middle fossa approach, but a strip shave is performed and the craniotomy is planned accordingly to the pathology that needs to be addressed. The pins are placed in an occipital location and in a frontal location. And again, the rule is used that the pins are placed below the equator of the skull so that the head falls into the pins and not out of the pins. We use this approach to access disease of the petrous apex, a subtemporal approach to basilar tip aneurysm clipping, lesions of the middle cranial fossa such as meningioma, and the internal auditory canal for a middle fossa approach for acoustic neuromas. It can be used as a half and half in conjunction with the terional and also with a retrosigmoid approach in a combined petrosal approach for more complex disease. We can alternatively use a full lateral position or the shoulder pad as was demonstrated in the picture. The head needs to be turned such that the sagittal sinus is parallel to the floor, and we pad and protect all bony prominences and elevate the knees. Again, we use a reflex position for the table to facilitate venous drainage from the lower extremities and to keep the head elevated to reduce intracranial pressure. We use lateral flexion of the neck if we wish, and this enables easier subtemporal retraction and looking down into the tentorial notch, such as approaching a basilar aneurysm. This enables gravity to retract the temporal lobe. So here's the final position for a subtemporal approach. In this case, we're using a large shoulder roll, but alternatively, we could place the patient in a full lateral position if the neck is difficult to be turned. For a midline parasagittal approach, we keep the sagittal sinus perpendicular to the floor, and we keep this approach absolutely midline. This is a standard Sutar flap that's drawn on this patient. Please note the biparietal pinning, and this allows the Mayfield head holder to be completely out of the way of the scalp incision. We'll keep the incision in this location or extended posteriorly if we wish to obtain a frontalis flap for vascularized closure of an anterior skull base defect. Midline parasagittal approach. It's similar to the positioning for a subfrontal approach, but the flexion of the neck depends on the surgical target, so that if we're approaching a fairly anterior skull base lesion, we may not wish to extend the head, whereas if we're trying to approach a suprasellar target or a vascular lesion or to a target through the lamina terminalis, we may extend the head more to have facilitated gravity retraction of the frontal lobes. We use this approach for hemispheric approaches. We use this for distal ACA aneurysms and around the genu of the corpus callosum, and we can use it to approach third and lateral ventricular lesions. For a midline parasagittal approach, we use the supine position as well, and we place pins such that there's enough room for the incision, and these may be placed in a bicoronal or variation. And then we extend the neck depending on the lesion of the approach. Again, if we want to come underneath the frontal lobes, we extend the head more to allow the frontal lobes to fall away from the anterior skull base. Here's an example of a patient in a midline parasagittal approach, and the flexion of the head depends on the pathology. And you can see the biparietal pins in this particular case, and you can see the patient with the head elevated to allow CSF drainage and reduced intracranial pressure for the approach. For a posterior parasagittal approach, we use a more semi-sitting position. Biparietal pins are placed once again, and the lesion is targeted using the image guidance system. The skin incision used depends on the pathology. We decide whether we need to expose the superior sagittal sinus or just take the bone flap up to the sagittal sinus on the ipsilateral side. With a posterior parasagittal approach, it can either be done prone in a supine or lateral position. If we target near the vertex, we use the supine or a semi-sitting position. If the target is more posteriorly, we'll use a prone position or a sitting position. Lateral positioning may facilitate interhemispheric exposure by allowing the dependent hemisphere to undergo gravity retraction. For the supine position, we use pin placement as would be for a midline parasagittal approach. We flex the bed to the position of the head and be mindful of risk of air embolism if the head is elevated above the heart. And again, we may rotate as needed to enable gravity to assist with the retraction of the parietal occipital lobes. Here's a picture of a patient in the posterior parasagittal approach for resection of a meningioma. And you can see we're using a semi-sitting position. Whenever the head is above the heart like this, we'll use a precordial Doppler to monitor for any potential air embolism when lifting off the bone flap or working around the venous sinuses. So this is a picture of a patient in the lateral position for a posterior parasagittal approach to a midline deep meningioma in the region of the tentorial notch. Here we're using the parasagittal approach to enable gravity retraction of the dependent hemisphere. This facilitates your vision interhemispherically and enables more exposure without formal retraction. The Concord approach is used for lesions of the posterior cervical medullary junction or upper spine. It is prone with the neck flexed, and the head is usually placed at or above the heart to facilitate intracranial pressure and brain relaxation. The arms are positioned laterally. Please note that we use two bolsters underneath the thorax bilaterally, and the head is placed in a Mayfield 3-point head holder, and the pins are placed in a biparietal position. The lateral suboccipital approach is visualized here. The lateral suboccipital approach is used for access to pathology in the CPA and lateral cerebellum and petroclavial region. It's a posterior fossa workhorse for all skull-based surgeons. It's also used to treat posterior circulation aneurysms, such as the vertebrobasilar junction or pica aneurysms. And we use it for microvascular decompression of the trigeminal or facial nerve, using a trigeminal approach or a standard traditional cerebellopontine angle approach, respectively. So the lateral suboccipital approach is used with the surgeon's preference for positioning. It can be done, for example, in the concord position or a lateral park bench. It can be done in the sitting position and also in the supine position. But we prefer a lateral approach for a couple of important reasons. It is easier to ventilate large patients in the lateral position compared to a concord position, and it minimizes venous hypertension by keeping the head without rotation. It's important to place the patient lateral with the very back of the patient close to the edge of the bed so the surgeon does not have to reach over the bed to access the posterior fossa. We place 2 pillows between the legs and flex the dependent leg to stabilize the patient. We secure the patient to the bed, as mentioned above, by placing tape and padded straps around the hips and over the shoulder, an axillary roll, and extend the ipsilateral arm and can secure it to the stand or torso if necessary. And we use traction to pull down the ipsilateral shoulder to open up the working area in the suboccipital region. The head rotation can be adjusted for pathology, and the amount of lateral extension can be adjusted to the pathology, such that we extend the head more laterally when we're performing a far lateral approach. We can place a lumbar drain or needle easily in the lateral position to enable and facilitate CSF drainage if necessary, and we're very careful with the amount of traction on the ipsilateral shoulder. And we always use motor evoked potential and somatosensory evoked potential throughout all of our cranial cases to make sure that we don't have any difficulty with positioning. And we monitor these and perform baseline monitoring before the operation starts. So here's the traditional lateral approach that we would use. And again, this is the workhorse approach for us to the posterior fossa. Please note that the patient is right on the edge of the bed and the taping is in place, axillary roll. Positioning of the pins is usually frontal with the 1 pin and occipital and suboccipital with the dual pins. The bed is placed in reflex and pillows are placed between the legs. Here's another such example using this for a far lateral approach, and we extend the head a little more laterally in this case to open up the region and make sure the upper arm is pulled inferiorly to open up the angle and to allow us to reach down further in the upper lateral cervical spine region. Far lateral approach is used for pathology located anterior to the brainstem and upper cervical spine. It's the lateral position we prefer to use, and neck with lateral flexion to open up this angle for working room. Again, the arm is pulled inferior and forward to enable more working room, and the body is padded and taped to the table to allow rotation and Trendelenburg and reverse Trendelenburg positioning. For midline suboccipital craniotomy, we use a prone position, and the pins are usually placed in a biparietal manner. Again, we use 2 bolsters under the thorax of the patient, and the head is flexed as necessary to approach the pathology. This midline access to the suboccipital craniotomy is used for fourth ventricular lesions, a telovelar approach, midline cerebellar approaches, Chiari decompression, and decompression for cerebellar infarction. It's also used for pineal region lesions. However, for larger people, I prefer to approach the pineal in a semi-sitting position. It's important that we place the biparietal pins before we position the patient in this case, and then flip into the prone position. The arms are tucked in the neutral position and secured to the bed, and the knees are flexed and the arms are elevated to ensure stability. We flex the chin at maximum 2 finger breadths from the sternal notch, and we lift the head while keeping it flexed. It opens up cranial-cervical junction. Here's an example of a patient planned for a midline suboccipital craniotomy. Please note that the table again is reflexed. The patient is well padded. Pins are placed in a biparietal position, and the neck is flexed. For the sitting position, it's important to preview the MRI study and see the angle of the tentorium. This will determine whether the sitting position is appropriate for lesions of the pineal, for example. The sitting position is ideal for lesions in the pineal region and the posterior fossa. The advantages of the sitting position allows gravity to allow the cerebellum to drop and fall away from the tentorium and opens up the surgical corridor. Elevation of the head minimizes venous pressures and venous bleeding. The cons are that you need an experienced and comfortable anesthesia team that are familiar with all the precautions that are necessary to perform anesthesia in this position. We use precordial Doppler and a central venous line, as there's increased risk of venous air embolism. There's also an increased risk of developing pneumocephalus that can cause problems postoperatively and may not be the most comfortable for all surgeons. So, firstly, after administering general anesthetic and obtaining line access, we put the head in a Mayfield 3-point pin headrest, usually in the biparietal region, and then slowly elevate the back of the bed and reflex the bed until the patient is in a seated position. And we elevate the back of the bed as necessary to approach the pathology, usually more if we're approaching lesions in the pineal area. The thighs and knees are bent, and the legs are elevated, and the neck is flexed. And again, we ensure that we don't flex the neck any more than 2 finger breadths distance between the chin and the sternal area. For the transphrenoidal approach, we use 2 different positioning. This is a picture of a patient in position for a standard microscopic transphrenoidal approach. If we're planning to use image guidance, we'll place the patient in a Mayfield 3-point pin headrest with biparietal pinning, as noted here. Please note that the head is turned slightly towards the surgeon on the right side in this case, and the face is placed parallel to the floor. The bed is reflexed slightly to elevate the head and reduce venous pressure, and the ipsilateral arm adjacent to the surgeon is rotated over the thorax and gently held in place using a wrist restraint from the left side. The trajectory and visualization of the cella must be optimized. We shift the head to the right with the shoulder just over the edge of the bed. And again, we secure the right arm across the body and the pins are placed in neutral position and the head is tilted accordingly. We then secure the patient to the bed and attach neuronavigation and expose for possible fat or fascial allograft harvesting. For the endoscopic approach, we place the patient supine on the operating table. The head is usually secured on a horseshoe headrest or a gel donut only. We tuck the right arm, and the left side is exposed for anesthetic access. The patient is secured to the bed, and the head is slightly turned to the right side for easier access for the surgeons. And we can use Trendelenburg and head turn to optimize the access. If we have surgeons on both sides of the bed, the head is usually placed absolutely in the midline. The patient here is placed on a donut with image guidance on the forehead of the patient, and the head is placed with just a slight turn to the right to facilitate surgeon access. Thank you very much.